Srinivasan sir, good evening, sir.
மீட்டிங் போறேன்.
Dr. Suresh sir. Suresh sir, are you with us?
Good evening, sir. Kanagvel sir.
Good evening, sir. Thank you, sir. Thank you for joining. Srinivasan sir, good evening, sir. Kanna sir, good evening, sir.
Good evening. Good evening.
Why, thanks,
Good evening, sir. Kanna sir. Good evening,
sir.
sir. Srinivasan sir.
Good evening.
Kanagvel sir. Why, sir? Thanks and all.
Somebody is joining from the operating room. Sir, Ibrahim sir, you're in the OT.
Sir, I am in a case. We'll finish in another 10 minutes, sir.
Sir, please, sir, please join. You can listen to us, and you are welcome to join whenever you are done, sir.
Sure, sir. Sure, sir. Thank you.
Thank you, sir. Thank you. Suresh Kumar sir. So good evening, friends. It's time by 2 minutes beyond 8 o'clock. So we have two presentations today. And the presentations are kindly contributed by Dr. Shanai sir from KMC Manipal. And the other presentation is from Dr. Sumati ma'am from Government Salem Medical College. So We have three eminent faculty, Professor Rahul from PHU IMS. We have Professor Ibrahim sir from Chennai and Madurai. He's a surgical oncologist. And we have Dr. Suresh Kumar sir, Professor of Surgical Oncology from Government Multi-Super Specialty Hospital, Government of Tamil Nadu at Chennai. So we have two presentations, one on early breast cancer, the other one is soft tissue tumor. Dr. Shanai sir is expected to join little later. So we'll have the presentation of soft tissue tumor first. So Dr. Santosh is from Government Mohan Kumaramangalam Medical College. So he'll be going first. So Dr. Santosh, please introduce yourself, your unit chief, your HOD, and then start your presentation.
Okay, sir. Thank you, sir. My name is
Good luck to you. Good luck.
General Surgery postgraduate. I am from Salem Mohan Kumaramangalam Government College. My unit chief was Dr. P. Sumati ma'am, and my HOD was Dr. Vijay Kumar sir. Today, I am going to present a case of soft tissue sarcoma.
Slide
Or
not
the
visible.
neck. Can I start, sir?
Yes, yes.
Please make it full screen, Kana.
Yes, yes, sir.
Suresh, one moment, Kana. Suresh Kumar sir, welcome. Suresh Kumar also joined. Professor Suresh Kumar, welcome, sir. Good evening, sir. I think let him settle down. Can you start your presentation, sir? Let him settle down.
Okay, sir. Thank you, sir. I'm going to present a case of soft tissue sarcoma over the nape of neck. The chief complaints, 50-year-old male farmer by occupation came with chief complaints of swelling over the nape of neck for past 1 year and pain over the swelling for past 4 months. The clinical picture was this was the swelling for patient presented with chief complaints. Then history of presenting illness, patient was apparently normal before 1 year. Later, we incidentally noticed swelling over the nape of neck, which was gradually progressive to attain the current size and not associated with aggravating and relieving factors. Then patient had a history of pain over the swelling for past 4 months only, while which was dull-aching in nature. No history of fever, no history of trauma, no history of presence of any other swelling in the body, no history of discoloration of skin over the swelling, no history of difficulty in using the left upper arm, upper limb, then no history of difficulty in neck and shoulder movements, no history of loss of sensation, numbness or tingling, no history of cough and evening rise of temperature, no history of loss of weight, and no history of spine pain. In past history, he had no comorbidities, not a known case of diabetes mellitus, systemic evidence, bronchial asthma, TB, epilepsy disorders. He has no history of radiation exposure, history of right side open hernioplasty done 10 years back. Only the positive surgery history. Then went for personal history. He consumes mixed diet, normal sleep and appetite. He has normal bowel and bladder habits. He is a non-smoker and non-tobacco chewer and non-alcoholic. Then family history, there was no relevant similar illness in the family. Case summary: a 50-year-old male came with chief complaints of swelling over the nape of neck for past 1 year and dull aching pain over the swelling for past 4 months. From this, the diagnosis we cannot make out. We have only two past history only, swelling and the pain only. So I would like to done further evaluation of this patient. Then I go for general.
No, hang on. Wait.
Yes,
Let's go to the first slide. Let the examiners ask the question.
Yes, sir.
Okay.
No, you can come.
You started presenting. You said, Santosh, you started presenting. You said, I am going to present a case of soft tissue sarcoma. That's not correct. You said swelling over the nape of the neck in presenting sir.
Okay, sir.
That should be the thing. Rajesh sir, please.
Suresh,
Santosh, you can
Yes,
have
sir.
a differential diagnosis, can't you?
Yes, sir. I can have differential diagnosis.
Yeah, so give us a differential.
So the first difference I always go for lipoma. Then
Anything else?
then cold abscess.
Okay. Anything else? You started with soft tissue sarcoma. What are the points in favor of this in history? Hello.
Yes, sir. Sir, in history,
Any
we have
points?
only swelling and pain that is not specific to the soft tissue sarcoma.
So, no, suppose this was soft tissue sarcoma. Do you have pain?
No, in soft tissue sarcoma, pain will develop only if there is a neurovascular invasions only, patient develop pains.
Okay, could you go to your next slide, please? Okay, next. Okay, next. Okay, I mean, how do you think bronchial asthma and tuberculosis and epilepsy disorders? We could have taken other past history also. So please carry on, sir. Dr.
No, sir.
Dr. Rahul.
Invited faculty of Suresh Kumar, sir.
Yeah,
Yes,
sir, this is Dr. Suresh Kumar. Good evening to all.
Good evening, sir.
Sir, you can go. You can start, sir, please.
So what is this N/K/C/O?
Sir,
Go to the
Past history N/K/C/O. What is that?
I think not a
in the
known
first
case
place,
of.
son.
not a known
Santosh.
case of diabetes
And-
mellitus, systemic absence, bronchial asthma, and tuberculosis and epilepsy disorders.
No, no,
Not
that
a
is
known
not.
case of.
Don't write all those things, which are not acceptable. Okay.
Yes, sir.
Yeah, they are not acceptable things. And then you started with the diagnosis of soft tissue sarcoma. That is also not correct, as Dr. Srinivasan said. And you should have
Yes, sir.
started there's a swelling in the nape of the neck is there. That would have been, we would have also started thinking what is that. Now you're given a direct diagnosis as a case of soft tissue sarcoma.
Yes, sir.
Okay, what is the cause of pain in the, doctor asked about that. What is the cause of pain in the soft tissue sarcoma? What are the various causes for that?
Sir, pain may be mainly due to the involvement of the neuromuscular invasion. If the soft tissue sarcoma invade the neuromuscular, and it will cause the pain.
Any other cause for that? So is it always the invasion, or it can also be just a compression in that area? That area is a very close compartment.
Close to, yes, sir.
The nape of the neck is a very close compartment. So if it is expanding, tumor is there, it will compress over all the surrounding structures. So not only the direct invasion is there, but also it can be because the compression there.
Yes, sir.
Then can an infection occur in the soft tissue sarcoma?
Yes, sir.
Yeah, so that is another cause, that if there is infection in the sarcoma is there, then that will also cause the pain there. Okay, so there are so many other causes for the pain in the neck, in the sarcomas. Okay.
What was the occupation? What is the occupation of this patient?
He is a farmer by occupation, sir.
Does it have any relevance here? Occupation.
Maybe more exposed to UV ionizing radiations.
Anything else? Any variety of herbicide? Okay, go ahead.
Can
When
any chemicals can cause the sarcoma?
Yes, sir. Arsenic, polyvinyl chloride, and arsenic. These are the common more incidents of causing the soft tissue sarcomas.
So that's why Dr. Rahul Khanna is asking about it. What is his profession?
He's a farm. Yes, sir.
Yeah, okay.
Where could he get exposure to polyvinyl chloride?
Sir?
Where can he get exposure to polyvinyl chloride? In which circumstance could he get exposure to polyvinyl chloride?
Sir, plastic pipes we are polyvinyl chlorides made up of.
Yeah, normally he won't get. When will he get exposure to polyvinyl chloride? Plastic is all right. How? If he's burning those plastics, okay.
Yes, sir.
Suppose he's burning those plastics and he inhales the fumes.
Yes, sir.
Then he gets exposure to polyvinyl chloride. Okay.
Yes, sir.
Okay.
We asked for discoloration of the swelling, discoloration of the body. With what in mind you asked about it?
Sir, the discoloration indicates whether the soft tissue sarcoma was arising from. If it is arising from angiosarcoma, I think the patient will have a reddish discoloration of the skin.
No history of swelling anywhere. Why? Can you name some condition which is can produce to? Why you ask for no history of swelling anywhere in the body?
It's, like Hodgkin lymphoma patient present with multiple swellings.
You know any sarcoma where there are pigmentations are there?
Sir?
Exoderma.
You know any sarcoma where there are pigmentations associated?
Angiosarcoma will cause.
That is the local pigmentation is there. But do you know any other sarcoma where there can be neurofibrosarcomas? No? Okay, somebody who has got the neurofibromatosis is there. Then the capillary spots may be there, pigmentations may be there.
Yes, sir.
Okay, and that patient may also have the neurofibrosarcoma.
Yes, sir.
Which type of sarcoma might be associated with multiple subcutaneous nodules all over the body? There are multiple subcutaneous nodules all over the body. One of them has started enlarging over the last 6 months and then ulcerated. So which type it could be?
Angiosarcoma, sir.
No, again, it will be neurofibromatosis.
Why are you stuck with angiosarcoma for every answer? Think if people are giving you hints, Santosh, go take the hints. Angiosarcoma is very rare.
Yes.
Subcutaneous nodules is
Okay, so which medical professional is susceptible to angiosarcoma? Now, because you're stuck on angiosarcoma, so which medical professional is susceptible to develop angiosarcoma?
More exposing to the radiation exposure patient.
Radiation, I think more special. Radiation exposure is a general thing. Which medical professional?
Interventional radiologists are more exposed to radiation exposure.
Those exposed to thorough-trust. Okay.
Yes.
Exposure to thorough-trust is linked with angiosarcoma. Okay, go ahead.
Do you know any virus which may be associated with the sarcomas? Any viral infection associated with the sarcomas?
Yes.
What happens in the HIV virus?
Kaposi sarcoma. Yes. From HIV, Kaposi sarcoma is associated with it.
So they can have the Kaposi sarcoma. You know? Yes.
So which virus is involved here in Kaposi sarcoma?
Sir?
Which virus is involved in the Kaposi sarcoma? Is it HIV virus or some other?
He doesn't know.
It is the human herpes simplex virus, not the HIV. Okay, although it's associated with HIV infection,
okay,
but it's actually the human herpes simplex virus, which is responsible for Kaposi sarcoma.
Yes, sir.
It is found in the HIV patients, but the cause is what Dr. Rahul Khanna is saying. You know? The patients who are having the HIV positive, they are likely to have the Kaposi sarcoma because of this infection.
No comfort. Yes.
Herpes simplex 1.
Yes.
Go ahead with your examination.
Words.
General physical examination. On examination, patient conscious oriented afebrile. There was no pallor, not ectric, no cyanosis, no clubbing, no lymphadenopathy, no pedal edema. The vitals was stable. BP was 130/80. Pulse rate was 86 per minute. SpO2 was 98% in room air. System examination and CVS S1, S2 had no murmur. In RS, bilateral normal bronchial bed sounds had equally, no added sounds. In CNS, central nervous system, no focal neurological deficit. Parabdominal soft and bowel sounds are present. This was the clinical picture of the swelling showing the involving the nape of the neck. Local examination after getting consent from the patient on inspection, the swelling of size 11 into 6 centimeter extending from the anterior. You can see the posterior aspect, posterior anterior part of the trapezius and It goes behind back nape of the neck and up to the spinous process, left spinous process of the scapula and extend up to the lower cervical and upper thoracic vertebrae, and the swelling was very close to the C5 and C6 vertebrae. It has a ill-defined edges, no ulcer sinus and dilated veins. Surface appears to be smooth. Skin over the swelling was normal. The swelling was non-pulsatile. On palpation, there was no warmth, not tender. All inspectory findings are confirmed. It was an irregular margins, no fluctuation, odd in consistency. Skin was pinchable. Mobility is restricted. Spinous process felt normally. Intervertebral space are also normal. On percussion, noted over the swelling. On auscultation, no bruit heard. Examination of the lymph node, no palpable cervical and supraclavicular lymph nodes. Movements of the left upper limb and necks are normal, and arterial system of the upper limb are also normal.
Oh, what is the plane of the swelling?
So the plane of the swelling
Hello?
was yes, sir. Plane of swelling
You
was
didn't mention about the plane of the swelling in your examination.
the plane of the swelling was muscular, sir, deep to muscular.
Deep to muscular means either it's subcutaneous, muscular. How do you say it is deep to muscular?
Because the mobility was restricted, sir. On a
So based on mobility restriction, you say it is a deep to muscular. So if it is superficial means what will be that? How will be the mobility?
even after the contracting the muscle, the mobility was free mobile. If it was a subcutaneous or
So in this case, but you didn't mention anything in your palpation finding about the plane of that is very, very important,
yes,
especially for the soft tissue tumor.
yes,
Okay. So you need to mention that.
yes.
Okay. You told that it is a sarcoma. How do you say it is a sarcoma? Sarcoma is a clinical diagnosis or a pathological diagnosis?
It's a pathological diagnosis only, sir. From
So how do you say it is a sarcoma?
we have to rule out the other diagnosis of that swelling, sir. For
No, see, when you give a diagnosis, well, you want to give it as a soft tissue tumor or you want to give it as a soft tissue sarcoma?
no, sir, it is a soft tissue tumor only, sir.
But your presentation is like soft tissue sarcoma. On evaluation, it may be. That is different. But on clinical examination, your approach should be open. Okay, it may be a soft
Yes,
tissue tumor or it may be a soft tissue sarcoma based on that. Okay, what are the points which may suggest that it may be a sarcoma on clinically? Yeah, you can say clinically, but what are the points to suggest that it is a soft tissue sarcoma? You can say it may be a sarcoma. What are the points?
Maybe size of the tumor was
Okay, size of the tumor.
then based on mobility and
A
consistency.
big life. Have you seen it? Yeah, one more thing you told about consistency, hard and consistency.
Yes, sir.
What do you mean by that? Can you qualify that? It's a firm or it is an hard? Hard means I always think about only the bone.
Not bony hard, sir, but not firm in consistency.
Okay. Okay, go ahead.
Say, my professional diagnosis, a case of soft tissue tumor, the nape of the neck. My clinical staging was T3N0MX.
Did you examine the lymph nodes of this patient?
No, sir. No examination of lymph nodes was no palpable cervical and supraclavicular lymph nodes, sir. No lymph nodes, sir.
So what lymph nodes you have examined in this patient?
I examined the supraclavicular lymph nodes and the cervical lymph nodes are examined, sir.
Of the same side?
Same and yes, the same side first. Then opposites are also examined, sir.
Not the axillary nodes?
Sir?
You have not examined the axillary nodes?
I examined axon nodes, sir, but no palpable nodes.
You are not
You
told.
didn't mention.
You did
Sir.
not mention all those.
Okay.
Because your mind is fixed with a soft tissue sarcoma. That is the reason.
Yes.
If I say it's a lymphoma, there are lymph nodes in the occipital region are there, and the tumor is arising for those lymph nodes.
Yes, sir.
So that is why you have to keep your mind open.
Yes, sir.
Okay.
See, basically, in examination, we want to assess how you are approaching. We don't want your diagnosis.
Yes.
How you are approaching the case. When the patient comes to you in open-mindedly, how you are approaching that. That is the thing we want it. Okay. We don't
Okay.
want your diagnosis. Okay. Anyway, how will you proceed?
Then I will go for investigations. I will done routine blood investigation. The non-invasive process I will first run USG and CT.
No,
Then I will
no.
go.
Why? How ultrasound will be useful for this case? Why do you want to do an ultrasound? You are just mentioning all the investigation, okay? But each and everything you should reason out. Why do you want to do an ultrasound for this surface swelling?
We can precisely define the size of the sarcoma from ultrasound.
Size of the swelling.
Size of this
Okay.
canosis.
Ultrasound is very
For
good
the size
both.
only you want to do.
Size you can
Yeah,
measure
go ahead.
clinically. Ultrasound is good for differentiating cystic from solid lesions. Okay,
Sorry.
that is very important here.
Yes.
Whether it's a cystic lesion or a solid lesion,
Okay.
what's
Yes.
the echogenicity of the lesion?
Can you have a cystic lesion in this area?
No, sir. No cystic lesions, sir.
No, but what cystic lesion can occur in this area? You cannot get any cystic lesion here.
Yeah, we can get, sir. Maybe it was the swelling was near to the spine. It may be meningocele was maybe present.
Meningocele is there at the time of the birth, isn't? But what can come later on?
Cystic hygromas.
Lymphangioma. You know?
Yes.
Lymphangioma may be there. It may be cold abscess.
Cold
Cold
abscess.
abscess, you know.
Cold abscess.
So ultrasound will tell you about that.
Yes.
That is the reason that why you are doing the ultrasound, not to measure the size here,
Yes.
but what type of the lesion it is and from where probably it is arising. Probably, in this area, it will just say that there's a diffuse swelling is there in that area. But at least you will know it is a solid or it's a mixed variety or just a cystic swelling. That can change your diagnosis.
Yes.
And what is this routine blood investigation? What is that?
So CBC, RBS, RFT, LFT of the patient.
So in this patient where there is a swelling in the neck is there,
Yes, sir.
what you will find in the CBC? What things can occur in the CBC in a patient of a swelling in the neck? Let me say it is a lymphoma. Can you get any finding in the CBC?
Lymphoma.
Yeah.
WBC counts will be.
Yes, there may be. Leukocytosis may be there. Yes. And differential, what can be there in the differential?
Neutrophils will be.
Eosinophilia.
Yes.
Yeah. So a good number of the lymphoma patients, they are associated with the eosinophilia. If you find the lymphocytosis, then what you will think in the blood picture?
Lymphocytosis.
Yeah.
First, maybe infection will be super infection of the swelling.
Maybe cold abscess,
Cold abscess.
tuberculosis there.
Yes.
Find the lymphocytosis, or in a case of lymphoma, you can find the lymphocytosis there. Okay, so you should know that what is that routine blood investigation and why you are doing that.
Yes.
But usually that should not be as placed as the first investigation,
Yes, sir.
Always whenever you are suspecting that the tumor is there, your first investigation will be the investigations which are targeted to make a diagnosis. Second set of investigations are investigations to check for the metastatic workup.
Yes.
Third set of investigations, all these routine investigations which are there. So tell in this patient, what are your investigations to make a diagnosis?
So for diagnosis, I will done MRI neck, then true cut biopsy. Sir. For definite diagnosis, I will go for true cut biopsy for this patient. Swelling. Sir.
But you mentioned FNAC/true cut biopsy. Why not FNAC?
Sorry,
Why do you want to go for
FNAC,
true cut biopsy?
true cut, from FNAC we didn't go for histological subtypes. It will give only it will give only sarcomas, only spindle cell sarcomas. But true cut biopsy we can go for histological subtypes. From that subtypes we can assess the prognosis of that patient and survival rate.
Oh, 1 minute. See, prognosis of the patient and survival, everything can be assessed in a post-operative. Only FNAC to say it is just a sarcoma. Why do you want to go? Okay. What are the principles of doing a biopsy in a soft tissue sarcoma? If you're planning to do a biopsy, certain things has to be followed out. What are all the things? Your incision should be in the...
Sorry, my incision will be in the vertical direction.
No. It should be in the your biopsy incision or scar should be in the future
Excision
major
part.
surgery excision. It has to
Excision.
be included in the
Yes, sir.
then, and you should not raise the planes. Bleeding should be avoided,
Yes.
and adequate tissue has to be taken. Drains, if at all needed, has to be placed very close to the skin, and you need to go for an additional, not only the biopsy, you need to go preserve the tissues for molecular, immunohistochemistry, all this thing has to be taken. Okay.
Yes, sir.
So you want to do a true cut biopsy. Okay, next.
Does the
Will you do
biopsy contribute
imaging
to the
first?
staging? Does the biopsy contribute to the staging in these patients? Does the biopsy report contribute to the staging in these patients?
Yes, sir. Soft
Staging
tissue sarcoma. Yes, biopsy was from biopsy depend on the cell proliferation, differentiation. Then mitosis staging also included in this soft tissue sarcoma. Sir.
How does it contribute to the staging? The histopathology report. How does the histopathology report contribute to the staging of soft tissue sarcomas?
So staging depend on if histological mitosis was less than 3 will be grade 1, 3 to 20 will be the grade 2, more than 20 will be the grade 3. Depending on that, stages will be given.
So will that make any difference in the treatment planning? Planning the treatment?
No, sir. Grading. Yes, sir. Treatment will be changed in histological types. Stages will be.
No. This lymph node involvement is likely to be more in which grade?
Sir?
Lymph nodal involvement is more likely in which grade? Grade 1 or grade 3?
Lymph node will be grade 3, sir.
So, in which variety you might choose to do prophylactic lymph node clearance? Even if they are not involved or not palpable. Even if lymph nodes are not palpable or not detected on imaging, but you might still choose to do a prophylactic. In which variety? So how will the biopsy contribute, come to your diagnosis, come to your health? High grade tumor, okay, grade 3. You might choose to do prophylactic clearance of the lymph node, okay, lymphatic basis. So what about the axillary lymph node? You didn't mention about the axillary lymph node in this patient. Will this area be draining to the axillary or not?
Yes, sir.
You mentioned only the cervical lymph node, but not the axillary.
In this patient, no palpable cervical axial lymph nodes, sir. No palpable axial lymph nodes.
Okay. No, will this area drain into the axilla or not?
Yes, sir. Drain into axial nodes, sir.
Okay.
Those which sarcomas they metastasize with the lymphatic route?
So
Usually
lymphatic,
sarcomas do not metastasize with the lymphatic route. They are the hematogenous route. But which are the sarcomas which metastasize with the lymphatic route?
so when we angiosarcoma will be the metastasis in the limbs.
Yes, angiosarcoma is one.
Yes, sir.
Other sarcomas,
There's a mnemonic which
Rhabdomyosarcoma.
Rhabdomyosarcomas, yes.
Shanghai sir used to say a mnemonic. Race. Mute Redmi.
Redmi Note 9, please mute yourself. Redmi Note 9, please mute yourself.
Rhesus is a mnemonic, or you can remember scream. So now tell me, what are these tumors with soft tissue sarcoma spread by lymphatics? Rhabdomyosarcoma, yes. Angiosarcoma, clear cell sarcoma, embryonal sarcoma, and synovial cell sarcoma. Santosh, are you hearing?
Yes, sir. Yes, sir. Hearing, sir.
That's what Professor Khanna sir wanted.
Okay, sir.
Which type of rhabdomyosarcoma occur in infancy and childhood? There are certain types of rhabdomyosarcoma which are typical for infants and children. Which variety? Santosh, can you hear?
Yes, sir. Yes, sir.
Hey, you say yes. I do not know. That's better word, man.
Yes, sir.
Don't keep silent, please.
Okay, sir.
Tell I don't know, sir. Please tell me. That's very
There's an embryonal variety. Okay.
embryonal.
Oh, yes, sir. Embryonal rhabdomyosarcoma.
Embryonal variety is very typical of childhood. It's very aggressive variety. And which organ is prone to develop rhabdomyosarcoma? Most prone in infancy. Which organ? And in adults is not involved. Which one? Urinary bladder.
Oh, yes. Yes, sir.
Okay. Suresh Kumar, sir.
See, you asked for MRI. Will you prefer MRI or a CT scan?
MRI, sir.
Why?
Because MRI shows the soft tissue extension of the tumors.
Yes, for bony part, you have a better delineated with the CT scan.
CT scan, yes,
for
sir.
soft tissue, it's always MRI. Okay.
Yes.
So what do you want to do further?
You did a true-cut biopsy. It is not conclusive. A big tumor. What is the next thing you will do?
So true-cut
biopsy. They said it. Pathologist says so.
Yes, sir.
They result a conclusion. Want more tissue. So what is the next biopsy you would like to do?
Incisional biopsy.
Right. What are the rules of incisional biopsy in a soft tissue sarcoma? Can I proceed, sir? Suresh, sir?
Yeah, please. Sir.
What are the rules? Number one, it should be a vertical incision.
Yes, sir. Well, yes, sir.
So next, when you want to do an excision, you have to include so it should be a vertical incision.
Yes, sir. Vertical.
Number two is don't raise the flaps.
Yes.
Take adequate tissue. Number three. Number four is
Drain out.
maintain hemostasis.
Yes, sir.
Absolute hemostasis.
Yes, sir.
No drain.
Yes.
If you want to keep a drain, keep it at the incision at the lower end. That's all. Not
Yes, sir.
a separate. These are the rules in an incisional biopsy.
Yes, sir.
In case if you want to do asked to do an incisional biopsy, this should be the rules.
Yes, sir.
Right.
And one more rule is don't keep a long time interval between the excision biopsy and the formal excision.
Okay.
Time interval should be kept short.
Yes.
If you do routine biopsy, don't keep a long time interval between the excision biopsy and the tuber excision.
Yes.
Yes.
You should not use cautery also, sir.
Yeah, that's what, sir. Don't raise the flaps. Maintain
And don't
hemostasis.
use cautery.
Yes, sir. Please, sir.
Yes, sir.
Santosh, next, what
Yes,
do you
sir.
want to do?
What are your
Tell
plans?
Santosh,
Yes, sir.
next, what do you want to do for this patient?
What is the
I
treatment?
have to say, I have to confirm from imaging, I have to confirm the extent of the tumor, sir, for planning for surgery.
Okay,
Then I have to.
that's all. The most important thing in sarcomas, man, you need to rule out the metastasis.
Yes, sir.
What
Metastasis.
investigation? Yeah, that is very, very important.
Yes, sir.
So
First, I have
what
to-
investigation you want?
Most commonly sarcoma metastasis to the lung only. So I have to take a chest X-ray. If I have any doubt, I will go for CT chest, sir.
Okay. Chest X-ray is normal, then you'll go for CT chest. If chest X-ray shows multiple Cannon-1, no need for CT. Okay.
Yes, sir.
So that is very important because before any soft tissue sarcoma, they have an high predilection for lung metastasis. In fact, if you suspect clinically itself, first they ask for a chest X-ray.
Yes, sir.
Okay. So now, as per your all investigation, it is a resectable disease. Okay.
Yes, sir.
So what do you want to do?
Then I will plan for surgery for excision of the
What surgery?
wide
What do you
excision.
mean by excision?
Wide excision.
How wide? How wide?
Even clearance of about 1 centimeter all.
All means?
Santosh sir is asking the question. He's told it's an operable tumor. So your answer should be perfect like a postgraduate. Please, okay. The exam. Sir, I would Luba.
Is the MRI done in this patient?
Wide
Santosh?
local.
Wide. Yes, sir.
MRI has been done in this patient?
Yes, sir. Done, sir.
Do you have the pictures of that?
Yes, sir. I have pictures.
From where it is arising?
This was the MR report, sir. A well-defined multilobulated 10.9 into 5.2 into 4.8 centimeter ovoid contrast enhancing solid mass over the left nape of neck and right upper posterior chest wall deep to the splenius capitis and trapezius and pressure erosion over the left lamina of the lower cervical spine and minimal extradural extension. Suggest a soft tissue.
And what is the biopsy report?
Yes, sir. But I done true cut biopsy for this patient, sir. It was positive for malignancy in favor of sarcoma, sir.
No, it's not true cut. It is an FNAC.
FNAC will not give you a sarcoma.
Yes, sir.
Yes,
sir. Yes, sir. It was a true cut only, sir. Wrongly.
Was an immunohistochemistry done?
No, sir. No, sir.
But has given on the true cut biopsy, what is the grade of this tumor? The other parameters?
They mentioned grade 3, sir.
Grade 3 tumor. Okay. CT chest is normal.
Yes, sir. CT chest lung parenchyma also normal, sir.
So after all these investigations, what will be your next step?
Wide excision of the tumor, sir.
So you will take that decision.
Any malignancy, what will you do, Santosh? Next, whom we will discuss with?
Will it be decision taken by one person only?
No, sir.
So what is that group called?
What is that called?
We have to, in MRI case, was the pressure erosion of the left lamina of the lower.
No. What we are asking is
Yes, sir.
treatment purpose. Will you decide by yourself or you need to have a team of doctors? We are just giving a clue, especially for oncological.
Yes, sir.
What is the board called? Multidisciplinary board or a tumor board, where it consists of radiologist, radiation oncologist, surgical oncologist, and medical oncologist, all these things. So we need to have a tumor board.
Yes.
And then based on the tumor board decision, we can plan it. Okay, so now you want to plan a wide local excision of the tumor in a 3-dimensional. Okay.
Yes, sir.
So as you say that as per the MRI,
Yes,
so the lamina of the lower cervical spine and minimal extradural extensions on that. So how you are going to give a clearance for this? You only told no 1 centimeter.
We will do laminectomy
3-dimensionally.
for this. Laminectomy for this involvement of the lamina of lower cervical spine. So.
Okay. For extradural extension, if you want to give an 1 centimeter margin for extradural extension means, what are all the things you have to remove it?
We cannot done, sir. Extradural clearance we cannot give.
What about the skin?
Basically, for a sarcoma, you know, what are the various type of surgical approaches? What are the various types of surgery which is done for any sarcoma?
Sir, if it is involving the extremities, we will do one joint above amputation of the extremities, sir.
For any sarcoma,
or if there is more,
give the basic principles. What are the various types of surgery which are done for any sarcoma?
Terminologies used. Okay.
Yes.
The amputation is the last resort. Before you embark on amputation, what are the other options? And amputation can only be done for limbs. You can't do it on the truncal part.
You know, what
there are terminology like intralesional excision,
what is marginal
excision, wide local excision, compartmental excision, then last is amputation or 4-quarter amputation or hindquarter amputation, depending upon the site. So that are the terminologies where you need to know in a soft tissue sarcoma surgeries.
Yes.
How will you plan the skin incision in the patient? Skin.
Sir?
How much skin will you say? How will you plan the skin incision?
So, sorry, sir. How much?
Incision. Skin incision in the patient. How will you plan the skin incision?
Horizontally, sir. Horizontally.
Pardon?
Horizontally.
Yes, sir.
What did you say? I couldn't catch you.
Is going to plan an incision in horizontal fashion.
Horizontal fashion. Okay. Why? And how much the entire overlying skin needs to be removed, or how will you determine that whether the skin can preserve over it or not? Can you pinch the skin over it? Is there edema of the skin? Is there beauty orange appearance in the skin? All those things.
Yes, sir.
If there's beauty orange appearance of the skin, what will do?
We have to excise that beauty orange.
You have to excise the entire skin over that tumor. Okay, so skin. So there will be problem with cover. Okay, so what is the situation in this patient?
Sir?
What is the situation of the skin in this patient? Can you pinch the skin? Is there skin edema? Is there beauty orange over the skin?
No beauty orange, sir. Skin was pinchable only.
Okay.
No edema also, sir.
But if there was, what would have been done?
If there's a skin involvement was present, we have to excise that skin also, sir.
Okay. Then what are the options for cover in this area? If you excise the skin, we won't be able to achieve primary closure in the
Yes, sir.
back.
If primary closure was not came from a skin excision, we will go for SSG.
Why SSG?
SSG.
In a
SSG
soft tissue sarcoma, in a patient like this, high-grade tumor, more than 5 centimeter, what you are planning, probably patient may need an adjuvant RT. If you put an SSG, the radiation, is it possible to give a radiation?
No, sir. SSG was
Then
contract.
SSG, how can you plan? Flap cover has to be planned.
Okay, sir. Yes.
Okay, what kind of flap you can use? Okay, tell me what are all the flaps available?
We can do rotational flap.
Okay. Next. Rotation, that is random rotation flap. Next. No, what are, just asking, what are all the other flaps you know? Pedicle based flap.
Yes, sir.
Okay, example. PMMC, pectoral myocutaneous flap or latissimus dorsi. Okay, then now commonly used plastic surgery, free flaps.
Yes.
Okay,
Yes, sir.
you should know what are all the problems. See, once the skin is involved, resection is maybe a easy one for you, but the cover is going to be important because you need to plan the adjuvant treatment, all this thing. Okay,
Yes.
so for that you need to have a good cover.
Yes, sir.
Okay.
Okay. What are
So
your
after
neoadjuvant chemotherapy in this patient before you go for it? This patient was operated?
Operated, sir.
Okay, before the operation, something was done or?
No, sir. We straightly operate this patient.
Okay, no neoadjuvant chemotherapy.
No neoadjuvant was given, sir.
And what were the muscles which were excised when the operation was done?
The PCS, sir.
It is going
okay.
lamina, isn't it?
In a soft tissue
We done also
sarcoma,
laminectomy also, sir.
in a soft tissue sarcoma,
Yes.
histopathology, what are all the things you would like to see? You have done a surgery, okay.
In histopathology,
what
we
are
have
all,
to some tumor margins. We have to first check, sir.
Very good. Margin is very important. Okay, then
Subtype of that sarcoma, sir.
okay. Histological subtype.
Yes, sir.
Then grade is very important in a sarcoma.
Yes.
Okay, then how histological type will influence your further management? You've been telling I want to see the histological type. So will you name it only as a sarcoma or you want to see it as a synovial sarcoma or MFH or leiomyosarcoma or RMS? Would you like to give like that? Is there any difference in that?
Yes, sir. From sarcoma subtypes, from histological only we can get angiosarcomas. Then
No. Why? How it is going to influence your further management?
Sir,
Santosh, you should not remain silent for a long time.
yes, sir.
You have to talk something.
Further management will not be changed for subtypes only, sir. It will give only survey and prognosis factors for the patient.
Which varieties are radio sensitive?
Sir?
Which varieties are radio sensitive?
Radio sensitivity.
Which varieties of sarcomas are radio sensitive?
Rhabdomyosarcoma.
As sir told, there are few sarcomas are chemosensitive, few sarcomas are radiosensitive, and more important, certain sarcomas are radio resistant also. So we need to know that. Okay. So example, chemosensitive tumors, Ewing sarcoma, RMS, rhabdomyosarcoma are going to be a chemosensitive. Again, radiosensitive, Ewing sarcoma, radio resistant, chondrosarcoma. So all this thing will influence your further management.
Yes.
Okay. So will this patient need adjuvant treatment?
Yes, sir. Based on biopsy, if a tumor margins are not clear, we are going to go for adjuvant therapy, sir.
So tumor. So if margins are negative, you won't go for.
If margins are negative, we have to keep the patient in follow-up, sir. First 2 years, we have to 3 to 6 months.
So okay, I'll ask in another way. What are the indication for adjuvant radiation, adjuvant RT in a soft tissue sarcoma?
If size is more than 15 centimeters, sir.
More than 15. Who was given this criteria? No, you can't enter just number. No, somebody has to be sale.
From AJC classification.
Okay. Size more than 5 centimeter is an indication. Then other indication. High grade tumor.
If it is high grade, sir. If it is was inoperable.
Deep seated tumor. No. I am asking about adjuvant treatment.
Adjuvant.
Okay. And deep seated. Okay. Then margin positive or close margin.
Yes, sir.
These are all the indication for adjuvant RT irrespective of your negative margin also.
Yes, sir.
What are the indication for adjuvant chemotherapy? Is there any role is there or not?
Adjuvant chemotherapy, no sir, no role. Neoadjuvant chemotherapy only, we have to reduce the size of the tumors. For that, we give the neoadjuvant chemotherapy. For inoperable cases, if there is if the tumor involving the neurological neuroinvasion, we give the neoadjuvant chemotherapy.
What about metastatic? Like you said, there might be pulmonary metastasis, cannonball and all. So which modality? Only chemotherapy will be effective in those patients. Okay, that's the only option there.
Yes, sir.
For metastasis in the lung or liver.
Yes, sir.
So what was the biopsy report in this patient? Tell us the histopathology report.
So histopathology report, that's it. Spindle cell carcinoma, the features suggestive of undifferentiated pleomorphic sarcoma, sir. With a margin shows all margins show infiltration, sir.
All margin shows infiltrations.
So what is the tissue of origin here then?
Sir?
What is the tissue of origin in this tumor then? Is it arising from which tissue? Spindle cell sarcoma, undifferentiated pleomorphic sarcoma. So what is the tissue of origin? Blood vessels, lymphatic, skin, muscle, fibrous tissue, nerve, muscles. Can a liposarcoma be pleomorphic variety? Can we have a pleomorphic variety of liposarcoma?
Sir, so what, sir?
Can there be a pleomorphic liposarcoma?
Yes, sir, pleomorphic liposarcoma.
Yeah, it can be. But if it is a spindle cell variety, then it is either fibrous tissue or muscle tissue. Okay, it's not likely to be liposarcoma.
Yes, sir.
If it is spindle cell variety, It can be only from fibrous tissue or muscle. So which is the commonest variety of sarcoma which arises from fibrous tissue? Commonest fibrous tissue sarcoma?
Desmoid.
No.
No, desmoid is not.
No, the most common sarcoma you see in back or anything from fibrous tissue.
Sarah's already given a clue. Fibrous.
Lipoma.
No, it is fibrous tissue, something fibrous.
It's always malignant.
So there are only 3 words, 2 words already given.
What is MFH? Santosh.
Yes, sir. So malignant
What
fibrous
is MF?
histiocytoma.
Yeah.
Malignant fibrous histiocytoma.
Okay. Okay. So how will you follow this patient? Now you're not planning any adjuvant therapy in this patient. Excision has been done. So what will be the
report
follow-up
shows that there is multiple, all margins are positive.
all margins are positive?
Yes, sir.
Where it's not written in the report. Where is the report?
Report was show you, sir.
So if all margins are positive, then where do we go from there?
Sir?
All margins are positive in this patient.
Yes, sir.
Then what is to be done then further?
So further we have to go for adjuvant radiotherapy. Sir.
No, re-excision. Should we go for adjuvant therapy? You didn't find any evidence of metastasis, isn't it?
No, sir. No metastasis, sir.
So it's a local regional problem. So did you sacrifice the skin in this patient, or skin
No,
was
sir.
not sacrificed?
No, sir. Not sacrifice.
So we need to do a re-excision of that area. Okay. And what Professor Khanna asked you, the muscles which were excised, adequate muscle excision was there because we were deep to the muscles.
Yes.
The skin was excised or not. Okay. So all those factors have to come in here. Okay.
Yes, sir.
I mean, radiotherapy is not a substitute for
Yes, sir.
re-excision.
Yeah, Santosh, always you know the principles. So radiotherapy is not a substitute for substandard surgery. Okay. If margins are positive, you need to go for re-excision. Need to get a negative margin. Okay, that is one thing. When we will consider only if it is a critical area,
Yes, sir.
like especially like vascular area or a critical bony lesion. Okay, in that case only we may compromise. That also will say with explaining to the patient that you have an high chance of local recurrence, and we may need to go for an adjuvant treatment. Okay.
Yes, sir.
So whenever the positive margin, directly don't go for the radiation. You need to, if possible, to excise with the adequate negative margin, you need to go for a re-excision. Okay.
Yes, sir.
Santosh,
So,
you told there was no skin excised.
Yes, sir.
Right? But
Yes,
in
sir.
sarcomas, always we need to excise some part of the skin. Whether you have done it or not, we have to excise some part of the skin over the tumor. Can you tell me which part it is?
Our incised edges, sir.
Yes. So whether it is a true cut biopsy or an incision biopsy, so that also will be contaminated. So always in soft tissue sarcomas, when you are planning for a wide local excision or whatever compartmental excision, whatever it is, you need to excise that also and give an adequate margin for that also.
Yes, sir.
And another important thing is in such deep-seated sarcomas or large sarcomas, we don't know up to what extent the tumor was extending. Only the image or the MRI alone is there.
Yes.
So for to help the radiation oncologist, you need to mark the edges of the tumor bed so that we will be able to cover it for during postoperative radiation.
Yes, sir.
Understood? This is very important.
Sir.
Santosh, anything intraoperative we could have done to
we done for this patient, sir.
Any intraoperative maneuver we could have done to felicitate the surgeon in this patient?
No, sir. Intraoperative.
We could have gone for frozen section of the margins intraoperatively. Okay.
Yes, sir.
That would have helped the surgeon tremendously. Okay. Because re-excision at this stage is a difficult proposition. But if intraoperatively frozen section biopsy was available, that the margins are not clear, then re-excision at that time would have been a very simple job to do. Okay. It's much more complex. It's become much more complex here at this point. Okay. So that facility should also be used in these patients if it is available. Frozen section biopsy.
Yes.
Or the margins correctly. Okay, I think your time is over now. You finished 1 hour.
Faculty, any other faculty would like to give their comments?
I think in this patient, because of the neck is a very tight compartment, it is going to so many muscles to the lamina of the bone it is going. This patient should have received the neoadjuvant chemotherapy, followed by surgery, followed again by chemo radiotherapy. So this is a case probably in this patient. All the modalities has to be used in this patient. Now, at this time, to go for the re-excision of all those will be very difficult, you know. And you are saying all margins mean not only the lateral margins, but also deeper margins also. Okay. So this patient should have been would have been a neoadjuvant chemotherapy followed by surgery, followed again by the surgery plus chemotherapy. That is my opinion.
And one more comment, like in these patients, we should have 2 surgical teams. One is the excision team and other is the plastic surgery team. Because if the same team is doing the reconstruction work, then there is a tendency for the oncosurgeon to compromise the margin to facilitate the closure. But if there are 2 teams involved, one is the onco team and another plastic surgeon team, then it is generally seen that the excision is much more wider. Because then there is another team which is coming in to do the reconstruction. So that, as was mentioned in the beginning also by some of the examiners, that a team approach is very important. And in the operation also, there should be onco team and a reconstructive team. There should be different surgeons. Then we always get a better excision margin.
Yes.
Thank you. Thank you, sir.
Thank you.
Thank you.
Thank you.
Kumar,
All
sir.
the best. Sir, yes, then
Any other comments, sir?
no comments.
Sir, Kanna sir, Shanai sir. Ibrahim sir, thank you for joining. Any comments from your side, sir?
Thank you, sir. Thank you, sir. I listened to the entire presentation. So one comment to Dr. Santosh is, during the inspection, you have told that about C5, C6 vertebra. So normally we don't see C5, C6 vertebrae. Even palpation itself is very difficult. So in inspection, you have to tell only bony prominence which are visible. If no bony prominence is visible, you can just tell us midline or 2 centimeters from midline, something like that. And another important thing is you have to mention there is no scar, because scar over a tumor is very common. So that has to be mentioned. So that you have to keep it in mind. And another only one question for you.
Yes, sir.
So I am telling, let us stop it with the clinical discussion. What are the points in favor of sarcoma? I am telling it is a cold abscess because that is more common. So cold abscess. What are the points in against cold abscess? Can you just enumerate that alone?
So from investigation point, there was no total count eliminated.
No. Only
First
clinical.
go one after
Only
the other.
clinical.
Go with the
Leave
history,
in
then with the
investigations.
clinical
Only
presentation.
clinical. Only clinical points alone.
Sir, maybe you should give the answer, sir. He's fixated to the tumor business, I guess.
Okay. Next, I'll ask only one question to you. So
Yes,
MRI and true cut biopsy, which you want to do first, and why?
MRI, sir.
Why?
Because it was a non-invasive procedure, first of all. Then after, if we done biopsy, mean it will cause local changes in the tumor site, sir. So we first go for imagings. Then.
Okay, fine. Thank you. So that's it, sir.
Thank you very much, sir. Santosh, do you have any questions for the faculty? You have any doubts?
So this patient came after 3 months. This was a 3 months after 3 months follow-up picture. Hello, sir.
Okay, ma. Listening. We are listening.
3 months follow-up picture. Now, yes, sir. Now we are planning for adjuvant for this patient, sir. Can we give adjuvant to this patient, sir? Adjuvant chemotherapy or radiotherapy? What will be difference? Then patient was not willing for another surgery also. Patient also not willing for chemo and radio. Now we are convincing him to for chemo and radio for this patient, sir.
Okay.
See,
So since there
radiation
is
Management
is
of this patient, what we
So this will be not an adjuvant chemotherapy in this patient. You will not use the term adjuvant here.
yes, sir.
Because the margins are positive.
Positive, yes, sir.
So it is not the adjuvant is only when you have done a curative things here. Okay. Locally you have done the curative things. So here whatever you are giving is the palliative now, Jay. So you are going to give the patient the palliative chemotherapy and the radiotherapy also there. But
Yes,
not
sir.
the adjuvant setting, is it?
Okay, sir.
And another important point, Santosh, is since it is already 3 months over since your last surgery,
Yes, sir.
patient may have developed metastasis also. So you need to reevaluate the patient and do a repeat metastatic workup. Because such patients will develop after margin positive surgery, if they don't take any kind of other non-surgical management, they will develop lung metastasis. So you need to reevaluate the patient, and based on the new staging, you have to give the treatment.
Okay, sir.
Faculty, can we move on to the next case?
yeah, please,
Yes,
sir.
sir. Yes, sir.
Thank you, Santosh. Thank
Thank
you,
you, sir.
and I
Thanks.
give my regards to your Professor Vijay Kumar sir,
Yes,
Dhanapal sir, and Sumati madam. Thank you very much for joining
Thanks.
this. You can stay with us.
Yes,
Dr.
sir.
John, are you with us?
Yes, sir.
Dr.
Okay,
John is
thanks,
kindly
Santosh.
contributed by Professor Shanai sir from KMC Manipal. Dr. John, please share your PPT. Please introduce your unit chief, head of the department, and then start your presentation.
Good evening. My name is John. I'm from KMC Manipal. The head of the department is Dr. Dinesh BV. My unit head is Dr. Sunil Krishna, and my guide for the presentation is Dr. Rajgopal Shanoy. History: 41-year-old female, premenopausal, cashew nut factory worker by occupation, presented to the OPD with a chief complaint of swelling in the right breast for the last 2.5 months. History of presenting complaint. Patient is apparently well 2.5 months ago. She noticed a lump in the upper outer quadrant of her right breast. Swelling was approximately 2 into 2 centimeters in size and gradually progressed to the current size. Patient gives history of pain over the lump, dull aching, non-radiating, no aggravating or relieving factor. Pain is non-cyclic and she did not take any analgesics for the pain. No history of nipple discharge. She has not noticed any retraction of the nipple. No history of any changes in skin. No other swellings in the opposite breast or axilla. No history of trauma to breast. No history suggestive of distant metastasis, low backache, breathlessness, cough, or abdominal distension. No history of significant weight loss. Past history: no history of radiation exposure, tuberculosis, intake of OCPs or hormone replacement therapy, previous surgeries on the breast, not a known case of type 2 diabetes, hypertension, or asthma. Personal history: patient consumes a mixed diet, normal bowel and bladder habits, adequate sleep, no history of smoking, tobacco consumption, or alcohol intake. Menstrual history and obstetric history: patient achieved MENARC at the age of 13, regular cycles of 3 to 4 days of duration of bleeding, 28-day cycles. Last period was 2 months ago. Married at the age of 24, T2L2, no history of abortions. First child was born when she was 27 years old, and last child at the age of 30. Both children full-term normal vaginal delivery. All children were breastfed for a minimum of 1 year. No history of breast cancer in first-degree relatives. No history of cancer in family like pancreatic, prostate, colorectal, or ovarian. Summary: 41-year-old female woman presenting with painful progressive swelling of the right breast since 2.5 months with no relevant family and no history suggestive of any metastasis.
At this point, we need clarification whether you mentioned that last menstrual period was 2 months ago. So we need to be sure whether the patient is pregnant or not. That makes a lot of difference in the treatment protocol involved here.
Yes, sir.
So what do you think? What did you ask? So you mentioned if you go back to your menstrual and obstetric history.
Yes, sir.
So here you written last period was 2 months ago.
Yes,
so
sir.
this needs a lot of clarification at this point. Rather than Regarding the imaging study is involved here in this patient or the treatment protocol, entire workup will depend a lot here.
Her periods were regular up until 2 months ago. She did not give any history suggestive of that could give suggestion of patient being pregnant, sir. Up until that, she was having regular cycles, sir.
Even if the family is positive for a breast cancer patient, what are the things you're going to ask?
Any first degree relatives who had breast cancer, and if they did have breast cancer, what age they were diagnosed with breast cancer, what treatment they took, and if there was any mortality, what age the mortality occurred. And for also other BRCA1 related associations such as colorectal, prostate in male relatives, and pancreatic, gallbladder, and other GI cancers, ovarian cancers.
No,
if somebody had a breast cancer.
Sir?
So you ask about the menopausal status of the patient. At what age the family member had the breast cancer, isn't? Ask about the BRCA. You ask about the treatment history. What is the other important, very important history which is you have to ask? If like mother had a breast cancer.
What age and whether it was premenopausal or postmenopausal breast
That
cancer.
That you have told you. Anything else?
If it was bilateral or unilateral breast cancer.
Yeah, that you did not tell. No? So that is very important, whether it was a unilateral breast cancer or the bilateral breast cancer.
And also about history of ovarian cancer.
Yes.
That also you need to bring out. Okay.
Yes, sir.
Ovarian cancer is almost got the same genetic background involved.
Yes, sir.
Do you know what are the various absolute risk factors for the breast cancer?
Sorry, sir.
What are the absolute risk factors for the breast cancer?
Absolute risk factors are age, nulliparity, age of first childbirth, and
absolute. I'm asking absolute.
BRCA
One are the relative. Okay, there are two types of risk factors are there: absolute risk factors and the relative risk factors. So what are the absolute risk factors?
BRCA1, BRCA2, genetic mutation.
Yes.
Family history of breast cancer and first degree relatives.
Yes.
Previous radiotherapy. Hormone replacement therapy.
They are all relative. Okay, the absolute risk factors are only 5 or 6. Age of the patient.
Age of menarche.
Not menarche. Age of the patient. If somebody is 70 years, she is very likely to have the breast cancer. If somebody is 30 years, very less likely to have the breast cancer. So age of the patient, family history of breast cancer, patient had a breast cancer on one side. That is also very important. Past history of the benign breast disease, which was diagnosed as what benign breast disease is likely to have the breast cancer? Benign breast disease?
DCI, so lobular carcinoma in situ, sir.
Any other tell? Any other which is disease, which is really a benign breast disease?
So DCAS is a benign.
No, sir. DCIS is not benign, sir. It is a in situ.
So I was asking benign disease which predisposes to malignancy.
ADH, no?
Yes, sir.
Atypical ductal hyperplasia.
Yes, sir.
And if the BRCA is positive. So these are the absolute risk factors. While all others which are there, like the nulliparity, age of menarche, age of menopause, obesity, smoking, drinking, all those are the relative risk factors.
Yes, what is meant by relative risk?
Yeah.
If we say that relative risk is 6, what does that mean?
The chance of the patient developing breast cancer over the normal population, sir, compared to the normal population.
Suppose like what Professor Khanna said that this atypical Dr. hyperplasia has got a relative risk of 6. So what does that mean?
She has 6 times more likely of getting breast cancer compared to a normal population, sir.
Right. So what's the difference between odds ratio and relative risk?
I'm not sure, sir.
Okay, go ahead. But like one session, like you made your slide, but you were almost reading out your slides. So the slides are not in a proper format. Okay, the slides should not be made in such a manner that you need to read out all the slides word by word. Okay, so that's not a good format.
Yes, sir. Sorry, sir.
Okay, go ahead.
General examination. Patient was conscious, oriented to time, place, and person. Moderate build, height of 147 centimeters, weight of 47 kg, and BMI of 19.4 kg. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. Vitals: pulse rate of 80 beats per minute in right radial, regular rhythm, normal volume, character. BP of 130 by 80 millimeter Hg in supine position, left arm, temperature 98.2 degrees Fahrenheit at the time of examination, respiratory rate 22 cycles per minute. A local examination, a patient was examined in a well-lit room in sitting position with arms by the side, arms raised, and hands on the hip. Both breasts were symmetrical, bilateral nipple areola complex, no discharge. Right nipple was seen to be 2 centimeters higher than left. No retraction of nipple was seen. No puckering and dimpling. Skin over the breast, normal. No ulceration, fungation, visible nodules, UD orange, no engorged veins. On leaning forward, both breasts fall forward equally. On raising both arms above the head, no puckering is seen and inferior quadrant of the breast appears normal. Axilla, arm, and thorax appear normal. Palpation, done in sitting position, semi-recumbent position, and in recumbent position. Left breast, normal on palpation. Right breast, no local rise of temperature, non-tender. A swelling of 3 into 2 centimeter, palpable in the right breast, mainly in the upper outer quadrant. Irregular surface, borders are ill-defined, hard in consistency, mobile with breast tissue. The lump was fixed to the breast tissue. No fixity to pectoralis major, chest wall, and skin. Rest of the breast, including nipple area complex, was normal. Examination of regional lymph nodes. One lymph node of 2 into 2 centimeter, firm, non-tender, mobile, in the central group of right axilla. No supraclavicular, infraclavicular lymphadenopathy. No lymph nodes in the contralateral axilla. System examination. Cardiovascular system. S1, S2 heard, no murmurs. Chest, bilateral air entry present, no added sounds. Per abdomen, soft, non-tender, no organomegaly, no shifting dullness. Per rectal examination, no abnormality detected. Spine examination, no spine tenderness. To summarize, 41-year-old premenopausal lady presented with progressive lump in the right breast, 3 into 2 centimeter, fixed to the breast tissue with ipsilateral single central mobile lymph node with no clinical evidence of metastasis. I would like to give a provisional diagnosis of early breast carcinoma of the right breast, which is clinically T2N1M0, stage 2B.
Why do you say carcinoma directly?
In this patient, that seemed to be the most likely differential diagnosis for this patient. Progressive breast lump with palpable axillary lymph nodes.
One thing you missed in the breast examination in the beginning, right in the beginning, which is important from the point of view deciding the treatment protocol in this particular patient. Like if you go to the photograph.
Yes, sir.
See, it is a very small volume breast. Okay.
Yes, sir.
Bilaterally small volume breast. So how does that make a difference?
For this patient, while offering BCS, it will be difficult because reconstruction might be difficult in a small breast, sir.
No, not reconstruction. Leaving a aesthetically acceptable breast mount would not be possible. Although apparently the tumor is small in size. Okay, T2 you mentioned 3 into 2 centimeter. But the tumor to breast ratio is adverse in this patient. Okay.
Yes, sir.
So this needs to be made a mention of in your examination finding, okay? Because it is going to have a bearing on the treatment protocol in this patient, because this tumor size in a large volume breast would have a different treatment, but in this particular small volume breast, this tumor size will have a different treatment entirely. Okay,
Yes, sir.
go ahead.
John, one more thing. It's being a female patient, you are not mentioned about pervaginal examination. You have just mentioned only perrectal examination. So this is very, as you know that the breast cancer may associated with ovarian cancer also. So pervaginal
Yes,
examination is important to look for that also. Okay, so you need to mention
Yes, sir.
that.
Yes, sir.
For how long do you think this patient had a breast cancer? By the examination, can you tell that for how long this lady would be having the breast cancer?
It would have taken at least 4 to 5 years to reach the current size, sir.
So tell what is the tumor doubling time?
It is 1 month. I'm not
1 month. It's approximately 100 days.
100 days.
So one cell to become 2 cells will take 100 days. So you know
Yes,
how
sir.
many multiplication it would have taken to become a palpable 1 centimeter lump?
Not sure, sir.
Approximately 30 multiplications. And that 30
Yes, sir.
multiplication will take at least 5 years.
Yes, sir.
So this tumor must have been there for more than 5 years now. Can you tell how many multiplications after that the patient can have the metastasis?
Another 30 multiplications, sir.
Even before that, 30 multiplication, it will become a centimeter palpable tumor. But even before that, it is said that after about 22 multiplications, the breast cancer can be metastatic breast cancer.
Yes, sir.
You know what are the various theories which are there for the spread of the tumor?
Yes, sir. There's a locoregional theory, and there's a Halstead concept. The Halstead concept says that it is
Locoregional is different from the Halstead concept.
Yes, sir.
What is locoregional? What is Halstead?
Locoregional is that it spreads both locoregionally and through the systemic spread simultaneously. Halstead concept is that it has a systemic spread through.
I think your name is different. Fisher is systemic. Halstead is locoregional. Okay.
Sorry.
So both
Fisher
are
is
not
a
correct.
breast.
Both are probably not
Totally.
correct. And that is why the third concept came. What is that concept? That is the spectrum concept.
Spectrum, yeah.
Okay, where it is both locoregional as well as a systemic.
Systemic, yes, sir.
Okay. Right. Okay.
How will you proceed, John?
First, I would a triple assessment of the tumor, sir. So first, clinical examination and history is done, following which I want to go for a tissue diagnosis, FNAC or true cut biopsy. Following,
No.
Before that, I would like to do a
FNAC or no. FNAC or true cut biopsy. You have to say one thing. Which one?
radiological investigation followed by true cut biopsy, sir.
Come again, please. Sorry.
A clinical examination, then mammography followed by true cut biopsy, sir.
True cut biopsy is the name of the needle, isn't it? It is a trade name. It is not the true cut biopsy. What you will say?
Core-needle biopsy.
Core-needle biopsy.
Okay. Yeah.
Yes, sir.
What is the diameter of the core-needle biopsy?
14 French, sir.
14 gauge.
14 gauge, sorry, sir.
And FNAC?
22 gauge, sir.
22 gauge. Good. Okay. So why you want to do the core biopsy and why not the FNAC?
To look for receptor status, sir, for the patient.
Okay, so what are the things you are going to look into that? In the
I want to see the ERPR status, the HER2 status, and the Ki61 status, sir.
Ki61.
Ki67, sir.
67. Yeah. Ki67. Yes. What other information you want to get from the pathologist in the needle biopsy?
The grade of the tumor, sir.
Yes. What else?
Biomarkers.
That you're told. ERPR
Yes,
and all those you're told. What other thing? Very important.
the types of carcinoma, invasive carcinoma, ductal or lobular type of carcinoma. So.
Neurovascular invasion.
Yes, sir, neurovascular.
Okay. So grade and the tumor and the neurovascular invasion. You know any?
What are the criteria which come into the Bloom-Richardson's grading system?
The number of mitosis, pleomorphism, and a size.
Tubule formation.
Yes, tubule function. Yes.
And what is the Nottingham prognostic index? What are the criteria which come into calculation for the Nottingham prognostic index?
I'm not sure, sir.
Okay, so tumor size, number of lymph nodes, and the grade of tumor.
Yes,
okay.
Sir.
So how is this immunohistochemistry? Like you said, we'll obtain immunohistochemistry, ERPR, HER2 status on the coded biopsy specimen. How is that going to affect the treatment protocol?
One is to plan the regimen of neoadjuvant or adjuvant therapy, whether to give hormone therapy. If the patient is ERPR positive, then patient can be planned for endocrine therapy. If the patient is HER2 positive.
No, before the operation, you mean?
Sir?
No, the endocrine therapy before the operation, before the...
No, sir. For neoadjuvant, we can, if it's HER2 positive, we will plan transfusimab. If it is HER2 negative, we will give anthracycline class, 4AC and taxane, sir.
Okay, if you are planning the neoadjuvant chemotherapy, this can have a bearing, immunohistochemistry. Okay.
Yes, sir.
If HER2 positive, you might add trastuzumab to the neoadjuvant therapy. Okay.
Yes.
Okay. So what is your treatment plan for this patient?
This patient, we have done a
before that,
MRM
now
for this
all that imaging studies you've done. Okay, you've not done the metastatic work, and most of all, you would have a urinary pregnancy test before all this. Okay.
Yes, sir.
You're never sure whether the patient is pregnant or not. The only method is to do a urinary pregnancy test.
Yes, sir.
That should always be done.
See, John, as per your diagnosis and early breast cancer, what metastatic workup would you like to do?
In early breast cancer metastatic workup, I would like to do a chest X-ray and a USG abdomen and pelvis. Sir.
In case of LABC?
I would like to also do a bone scan or a bone scan, CT thorax and abdomen, or a PET CT, sir.
PET CT. Okay. So for early breast cancer, chest X-ray and ultrasound is suffice. So what do you want to plan?
When you have done the
clinically, it is T2?
T2
John.
and 1, sir. T2 and 1.
Okay.
And yes.
Okay. So what do you want to do?
In this patient, after taking the baseline investigations and routine investigations such as LFT, I would like to take the patient up. We have done the mammogram and also the USG X-ray and USG and X-ray were normal. So I would like to take this patient up for a modified radical mastectomy with axillary dissection. So,
John, you have done the LFT in this patient.
Yes, sir.
What are the things you're looking for?
We need to look for the liver enzymes for baseline, and also if it was a locally advanced tumor, we need to also look for the total bilirubin, sir.
Which enzymes you are interested?
Sir?
Which enzyme you are interested?
ALP, sir.
So ALP is raised. You have done the LFT, ALP is raised. What does that mean?
There could be a chance of bone. Not sure, sir.
Either the patient has the liver mets or the patient has the bone mets.
Bone mets, yes.
Okay, so how will you decide whether this ALP which is there is because of the bone or because of the lung, because of the liver?
By doing a bone scan and a USG abdomen, sir?
No, biochemical investigation, which can help you. It can direct you here. Some biochemical investigation.
To do a not sure, sir.
You do the bilirubin is one. If the bilirubin is raised, it is likely to be the liver one. You will do the calcium. If the calcium is raised, then it is likely to be the bony one. No?
Bony, yes.
And then you can do the subtyping of the alkaline phosphatase. One is a stable type, another labile type. So in one, it is the stable one, another is the labile variety. So you do the subtyping of the alkaline phosphatase, do the serum calcium and do the bilirubin, and that will tell you whether it is the liver or the bone.
Yes, sir.
Okay. Okay, go ahead. So what are you planning now?
So in this patient, we did a mammogram. In the mammogram, there was a radio-opaque lesion with speculation. And also on the medial lateral oblique view, we can see radio-opaque lesions in the axilla also. So the mammography of both breasts was performed, and it showed a poorly circumscribed radio opacity with speculated margins, 1.3 into 1 centimeter seen in the outer quadrant of the right breast. No evidence of architectural distortion, calcification. Retromammary space is clear. Nipple areolar complex is normal. Correlated phonomammography showed irregular hypoechoic lesion with speculated and angular margins, 1.3 into 1 into 1.4. And the lesion is approximately 3.5 centimeters from the nipple. Highly suspicious for malignancy. 2 subcentimetric right axillary lymph nodes with a face fatty hilum, largest measuring 12 into 6 centimeters, query pathological node. So the right breast was BI-RADS 4C. We have done a chest X-ray and USG abdomen pelvis, which was found to be normal.
John, 1 second. Do you need
Yes,
to
sir.
do a bilateral mammogram or a right-sided mammogram is sufficient?
Bilateral is required, sir.
Why it is required?
To rule out any lesion in the contralateral breast, and also to see if there's any lesion in the contralateral axilla, which could increase the stage of the disease, sir.
Yes, main indication is there are many cases of non-palpable lumps which may be detected by mammogram. She is already a 41-year-old lady. She might have not undergone a screening mammogram previously. So the opposite side mammogram will be like a screening mammogram, and this side will be an investigative or diagnostic mammogram. So always it should be a bilateral mammogram. Even if sometimes patients may come with a unilateral mammogram because only one side the lump is there. Even then you have to prescribe a bilateral mammogram. Yeah, you can go ahead.
Yes.
When another reason is why you should do it, that there might be evidence of ductal carcinoma in situ on mammogram. Ductal carcinoma in situ is frequently not palpable, and that will also affect your treatment protocol, whether you do a wide local excision or a modified radical mastectomy. There will be evidence of ductal carcinoma in situ outside the tumor also. Okay.
Yes, sir. I'll go ahead.
Yeah, proceed.
The patient had an outside FNAC report, which showed a lump in the right breast, positive for malignancy. Features are suggestive of invasive carcinoma. The patient underwent a right modified radical mastectomy. Introp findings showed a right breast 2 into 2 centimeters hard, lump in 9 o'clock position, multiple enlarged level 1 lymph nodes. The histopathology report showed right
No.
breast
Wait.
Sorry. Yes,
Wait. What kind of mastectomy you want to plan?
Modified radical mastectomy, Auchincloss.
What are the types here? What are the types you know?
Patties, scallions, and Auchincloss.
Patties, cannulon, and Auchincloss. What are the difference in these three?
In patties, we remove the pectoralis minor muscle to remove the level 3 lymph nodes. In scallions, we incise we cut the muscle to remove the level 3 lymph nodes, and in Auchincloss, we retract the muscle, sir.
Okay.
What are the lymph nodes which are there in the axilla?
Sorry, sir?
What are the various lymph nodes in the axilla?
In the axilla?
Not clinical. At the operation.
Levels.
There are 3 levels of lymph nodes, sir. The level 1 lymph nodes are lateral to the pectoralis minor. Level 2 is below the pectoralis minor, and level 3 is medial to the pectoralis minor. Level 1 include the anterior, posterior, lateral lymph nodes. Level 2 includes the central and the interpectoral rotors node, and level 3 includes the apical lymph nodes, sir.
You know who gave these labels? You know who has given these labels? What are they called as?
Not sure, sir.
They're called a Burge. Burge level. B-E-R-G, Burge levels.
Yes, sir.
What is the other name of the apical node?
Infraclavicular.
No, what is the other name for that apical node?
Not Halsted.
Halsted, yes. Halsted node.
Halsted nodes, yes.
Halsted node, yeah. Did you discuss with this patient, or did you directly go for the MRI in this patient? Did you give the option to this patient or not?
Yes, sir. We gave the option, but we explained regarding the need for radiotherapy post-operatively, and a patient was not willing for the same, sir, and also had financial constraints, sir.
So is this patient a candidate for the BCS or not? Yeah.
Because of the small breast size, sir, not an ideal candidate for breast conservative surgery, sir.
No, the tumor is only 3 centimeters, which is located in the outer quadrant.
Yes, sir.
So you can do the oncoplasty in this patient.
Yes, it is possible, sir. But
so you should have, yeah, this patient should have been explained for both, no?
Both. Yes, sir. They were explained, sir.
Yeah. Okay.
Actually, John, the patient is clinically N1, right? So N1,
yes,
if it is positivity by pathological staging, the patient definitely needs an RT also. So
yes,
even
sir.
after doing an MRM, she may need an RT. So this
Yes,
RT
sir.
alone cannot be a contraindication for exception to exclude her from BCS. So what will be the gold standard for EBC, like T2, N1, M0? What is the gold standard treatment?
Gold standard treatment will be MRM or BCS with axillary lymph node dissection.
I am asking whether it is BCS or MRM. That's the thing. In other
BCS,
words,
sir.
in which group of patients you will do a BCS? So it is already it is already very small. You have mentioned it is an early breast cancer. Still, you don't want to do a BCS, or you want to?
I want to, sir.
Okay. So you are planning for a BCS. You have got an FNAC report alone which says as invasive carcinoma. Do you think with the FNAC you will be able to tell it is invasive carcinoma? Is it possible?
Sir. No, sir.
So do you want to rely on that FNAC and go ahead and do an MRM? Or you want to do a repeat FNAC or a repeat something else, repeat investigation, repeat biopsy or something?
Yes, I would like to do a true cut biopsy before going ahead for a BCS if I'm planning for a BCS.
No, whatever treatment, any surgical treatment, before doing any surgical treatment, whether you are doing a BCS or an MRM, you need to do a true cut or a core cut biopsy So suppose with relying on the FNAC which was done outside, if the treatment final histopathology comes as DCIS, so then will your surgery be appropriate or it is an over treatment?
It is an over treatment, sir.
Yes. So before contemplating for an axillary dissection or before contemplating for a modified radical mastectomy, it is MRM is a morbid surgery, not for surgical aspects, but because of cosmetic aspects. So before doing contemplating on any kind of morbid surgery, you need to confirm the diagnosis. Whether the patient is willing for MRM or BCS, that is immaterial. A core biopsy is mandatory nowadays in any case of surgical management of thing. And also, even if you are planning for a neoadjuvant, as you said earlier, you need to have a receptor status and IHC reporting. So a core biopsy is mandatory before any surgery. Okay.
Yes, sir.
Yeah.
Suppose if, and one more thing, in an exam, don't say the cost is the factor. Okay, you have to give the proper treatment to the patient. Cost comes next or in a clinical practice. So since the patient doesn't have money, so she opted. So you can't tell like that. Okay. Suppose the patient wants BCS. So how will you do?
As in the steps of BCS, sir?
Yeah, no, you just tell me what are the contraindication, absolute contraindication, relative contraindication. Based on that, how will you convince, how will you select?
Absolute contraindications include absolute contraindications for radiotherapy. If the patient is pregnant, prior radiotherapy, if patient has any connective tissue disorders, relative contraindications are if patient had previous surgery to the breast, if it is a multicentric lesion, and also if it's a small breast, sir.
It's a small breast. So these are all the some contraindication.
What about
so
family history? Any role of family history here?
If the patient has a family history or a patient is BRCA has a BRCA mutation in the family, then there's a high chance of recurrence. So ideally would like to go for a mastectomy. So
is that a high chance of recurrence or something else?
High a chance of bilateral breast carcinoma.
So what? So you want to remove the opposite side breast also because there is a high chance. So patient has come with a right-sided breast lump. You want to do a bilateral mastectomy now?
No, sir.
Then what is the indication like?
Sorry, sir.
No. You told because the family history and BRCA positivity, patient may develop a recurrence, right?
Yes, sir.
The same amount of chance or risk is there in the opposite breast also, right? Because it is the same patient. So would you like to do a bilateral mastectomy or a prophylactic mastectomy on the other side? Or you want to do just a MRM?
In BRCA patients with BRCA mutation, bilateral mastectomy can be advised, sir.
No. It is like can be advised, should be advised.
Should be advised. Should be advised also with hormone therapy and yes, sir, hormone therapy.
I think you need to be a little clear about this. So the main thing is if it is a BRCA positivity, you can go ahead with as you told, like prophylactic mastectomy on the other side if the patient is willing. If it is just a family history and no BRCA positivity, and if there are any other family members positive, then it is better to go a modified radical mastectomy rather than going for a prophylactic.
Yes.
Okay. Yeah.
So when you are considering BCS, so what margin will you give? What
in BCS, I would like to give a ink-free margin for the specimens. The ink margin should be free of tumor, sir.
Free of tumor. So that is the idea. Suppose if your histopathology shows one is invasive carcinoma at margin, other scenario is DCIS, other scenario is LCAS in your resected margin. So what will you do for each?
For DCIS, I would like a 2 millimeter margin, sir. For early breast carcinoma, I would like ink margin.
No. In your resected specimen, margin shows one scenario is invasive malignancy, other scenario is DCAS, other scenario is LCAS. So how will you proceed further?
If in the first scenario, if it's showing invasive carcinoma in the borders, then a resection of the margin should be done. If it is DCIS, the margin should be at least 2 millimeters. And if it's lobular carcinoma in
No,
situ,
I'm not
then
asking about DCAS margin. What is the margin? I'm asking if DCAS is the margin. As you say, the ink margin shows DCAS. What will you do? Invasive carcinoma, you told that I will re-excise.
Yes,
in
sir.
DCAS, what will you do? In LCAS, what will you do?
In DCIS, again, revision of margin with 2 millimeter
Yes.
margin, sir. And
so again, the revision has to be done. Okay. For LCAS?
Mastectomy, sir.
No, LCAS, you can leave it because it's a precursor lesion only. So no need for anything for LCAS. Okay.
Yes,
for invasive malignancy or DCAS, you can go for re-excision. If cosmetically acceptable, re-excision. If not acceptable, you have to convert it into mastectomy. Okay.
Yes.
For LCAS, you can keep under observation.
How will you label the specimen in the BCS?
In the BCS, I would like to paint each side of the tumor with a different color, and also I would like to label it with a radio opaque clip, sir, and also with a thread, sir. For the
what type of the color you are going to use, which will not get dissolved in the formalin?
Formalin, yes, sir.
No. So what colors you are going to use? Or you do something else?
Inking the margin, sir. Inking each margin with a different color, sir.
You know, putting the sutures there?
Yes, sir.
That is probably used much more, putting the sutures. So how you are going to put the sutures?
For the one for the superior part of the lesion and one for the lateral part of the lesion, sir.
So how will you know which is the superior, which is the lateral? How the pathologist will know that?
And the pathologist has to be mentioned long thread for superior and short thread for lateral. It has to be conveyed to the pathologist, sir, on the
long lateral, short superior.
Short superior.
And how the pathologist will know the anterior and the posterior margin?
Double thread, sir.
Double, yes.
A part
double
of the skin
deep for
has to
deep.
be
Double for depth.
Depth.
So double suture in the depth. Or if you have removed a part of the skin, usually it is not removed in the BCS, but if you removed a part of skin, so that will become anterior and the other side will become posterior. Okay. Then what else has to be done in the bed of the tumor when you're doing a BCS?
Clips have to be placed in the bed of the tumor, sir.
Yes.
Any other option we can do?
Sir?
Any other option?
A specimen mammography, sir? As in?
No, for the radiotherapy. Yeah, at this point.
Inking of the area.
For the radiotherapy, for the adjuvant radiotherapy.
Brachytherapy can be given, sir, for us.
Brachytherapy tubes can be put at the time of operation. While you're doing a wide local excision, at that time we can insert the tube, in which we'll feed the iridium or cesium bias for the post-operative brachytherapy. Okay.
Yes.
So the patient will be saved from teletherapy. Patient will can receive brachytherapy.
Yes, sir.
Is the BCS over, or you need to do anything else also, John? Is the BCS over?
Sorry, sir, I couldn't.
No, is the BCS surgery over, or you have to do anything else?
Axillary lymph node dissection is also required, sir.
Okay. So how do you do? Through the same incision, same position?
No, sir. With a separate skin crease incision at the axilla, sir.
Okay, and how do you place the drain in the main wound and also in the axilla? Where will you place the main drain?
In the bed of in the axilla, and from the axillary dissection bed, sir, for the axillary wound, and main. I'm not sure, sir, for the main.
Have you ever seen a BCS before?
Yes, sir.
Okay, so usually we don't keep a drain in the main wound.
Main. Yes,
We don't keep a drain in the main wound, only in the axilla.
Axilla,
And for MRM, do you keep drains?
yes, sir. Both for the chest and the axillators. Two separate drains, sir.
Two separate drains. So usually when you are doing an BCS for the axillary dissection, you keep a single drain alone, and no drain for the bed, tumor bed.
Yes, sir.
And if you have done a true cut biopsy prior, it is always important that you include that in the skin incision. So that part of the skin has to be excised along with the tumor, not separately, along with the tumor in toto.
Yes, sir.
Yes.
Okay, how will you proceed after surgery? What are all the things you'll look into the histopathology report?
I would like to look for the margin, sir.
Straight away margin. In a mastectomy, MRM, do you worried about margin?
No, sir. So,
yeah, tell me, you have done an MRM. What are all the things you would like to see?
In MRM, the type of tumor, whether it's invasive or what the histopathology, the grade, the number of lymph nodes, and the number of lymph nodes.
Number of lymph nodes harvested and involved,
and the number which is involved, and also if whether there was any lymphovascular invasion. And yes, sir.
Then that's all.
Then the receptor status, and whether in the lymph nodes, if there was any extracapsular spread, sir.
Okay, what are the receptors?
So what you can do is you can
study.
categorize or separate into two: the main tumor characteristics and axillary node characteristics.
Yes, sir. Sorry, sir, I didn't get the last question, sir.
No, IHC, immunohistochemistry, what are all the things you see?
I look for the ERPR status, the Hertinu status, and the Ki67, sir.
What is the Ki67 denotes?
It denotes the rate of mitosis, sir. The growth of the rate of growth index.
Yeah, proliferative index. Okay. So how will you classify breast cancer molecular classification?
Luminal A, luminal B, basal, triple negative, Hertinu enriched.
How do we distinguish between
so what is
type A and type B?
Sorry, so I didn't get the question, sir.
The distinction between luminal type A and type B, how is it made?
The Ki67 value, sir.
What's the cutoff?
40, sir.
14%.
14, yes, 14.
Less than 14% is luminal type A. More than 14% is luminal type B. Okay.
Yes, sir.
And triple negative does not come into this nomenclature.
Yes, sir. It is a type of
negative. Yeah, triple negative is not synonymous with basal variety. Different.
Yes,
so what is the basal variety?
It's
not synonymous with
basal variety is a highly aggressive type of tumor.
So how do we recognize the basal variety?
With a high Ki index and which is ERPR negative, sir.
No, that's not a criteria for basal variety.
High grade tumor and high Ki 67 index, sir.
No, again, no.
I'm not sure, sir.
It is a cytokeratin 5 and 6. On the basis of cytokeratin, okay. Not on the basis of the ERPR or HER2 status.
Yes.
So basal variety and the triple negative variety have got a lot of overlap, but they're not synonymous. They're still not synonymous. Okay, and triple negative is not in the nomenclature for the molecular subtyping of breast cancer.
Yes, sir.
So what is the histopathology? MRM specimen?
It is right breast MRM, invasive breast carcinoma, grade 2. 9 out of the 18 lymph nodes isolated shows metastasis, ENE positive, and lymphovascular invasion identified. All margins are free of tumor. Pathological grading of PT1, C, and N2.
So what do you want to do further? Receptors? What about the receptors?
Not mentioned, sir.
What does T1C
That's very
mean?
important, no?
Okay.
No, without receptors or IHC study, how you are going to plan your treatment, adjuvant treatment?
Yes, sir. This patient has the specimen has to be sent for receptor study, sir, which is yet to be done, sir.
Yet to be done. It's awaited.
What is
okay?
T1C? What is T1C here?
T1C is it is 2 millimeter, 1 to 2 millimeters, sir. 1 to 2 centimeters.
1 to 2 millimeter.
No, centimeters. Sorry.
No, not again. No, not correct. 1 to 2 centimeter. No. And what is then
What is T1? First, T1.
No, first tell what is T1. Yeah.
Sir?
First tell T1. What is T1? PT1. What is T1?
T1 is when the lesion is less than 0.5 millimeters, sir. And T2 is 0.5 to 2 centimeters. 2 to 5 centimeters. 3 is more than 5 centimeters, and 4A is if there's involvement of if there's
what do you say? T1 is 0.5 centimeter.
T1 is
directly T2 you are going for 2 to 5 centimeter. In between what happens?
So what is the stage between 0.5 to 2 centimeter? What does it? Which stage it is? T?
T1A, 0.5 to. Sorry. Can I repeat the?
Yeah. Relax.
T1 is,
relax and.
T1 is less than up to 2 centimeters, sir. T2 is 2 to 4 centimeters, and T3 is more than 4 centimeters, and T4 is based on involvement of skin.
Yes, John's classification.
Chest wall.
Whose classification? It is 4 centimeter or 5 centimeter?
5 centimeters. Sorry, 5 centimeters.
Okay. Anyway, what do you want to do now?
On T1 is less than 2 centimeters. Okay.
Yes, sir.
Right. There is a term what is called T1MI. What is that?
Micro, sir. If it is.
So that is less than 1 millimeter.
1 millimeter, sir.
Okay. Then it is T1A, 1 to 5 millimeters. T1B,
yes,
5 to 10 millimeters. T1C, 10 to 20 millimeters. Okay.
Yes, sir.
Yeah.
And there's also TIS. Besides what Dr. Khanna said, TMI, TIS. What is TIS?
In situ, sir.
No, isolated cells. Okay, isolated tumor cells.
Yes.
So
What
is
LCIS
in situ tumor?
Sir?
John, is it LCIS, lobular carcinoma in situ, comes under in situ tumor? No?
No, sir. No, sir.
So only DCIS.
It is a marker. Only DCIS, yes.
What is N2A here? N2A.
N2A, if there is level 1-2 lymph nodes, which are matted, sir.
No. You are telling about the clinical classification. We are discussing pathological staging, right? Pathological staging. Pathologically, yes. What is N2A? Pathologically, how do you classify N1, N2, N3? So specify as C to B. Yeah.
I'm not sure, sir. 3 to 4.
Okay, no problem. So how will you proceed further?
What is PN1, PN2, PN3? Here, in this slide, you have PT1, that's okay. For a node, you have used prefix and the term like there is a spelling mistake. Can you combine
sorry?
pathological staging and clinical staging together?
Sorry, sir.
John, are
Couldn't
you
hear
there?
you.
John?
Yes, sir.
No. In the slide, you
Yes,
have mentioned
I
as
think.
PTNM, PT1.
Yes, I think there was a mistake. Said
C
should be.
C comes for the T1C, right?
Yes, sir.
Okay. So just classify N1, N2, N3 pathologically alone.
Pathologically.
Yeah.
Pathologically, ipsilateral lymph nodes, N is 1 to 3 lymph nodes, N1. N2 is 4 to 6. I'm not sure of the rest.
No, it is N1 is 1 to 3 and N2 is 4 to 9 and N3 is more than 9 or 10 and above.
Yes.
So you have harvested 18 lymph nodes. That's very good dissection. Suppose you have harvested only 5 lymph nodes and 4 out of 5 is positive. So can you, what is your take on this?
It was an inadequate lymph node dissection. So at least 10 lymph nodes are required, sir, for an adequate lymph node dissection, sir.
So it is not only inadequate lymph node dissection, sometimes pathologists might have not done the dissection of the specimen.
Yes.
So the ideal thing is you can do a specimen dissection and send the lymph nodes individually to get a better yield.
Yes, sir.
So after the surgery, postgraduates in some of the institutes, they dissect the nodes separately from the fat and send it separately so that it will be easy for the pathologist.
Yes, sir.
Okay, John, why would N2A be important from the treatment point of view, adjuvant treatment? N2A.
If a patient has large, bulky N2A lesions, then we should plan for adjuvant chemotherapy, sir.
No, anything else?
So is it the node which determines the adjuvant chemotherapy? Suppose if the patient is having a T2 tumor, no nodes, will you give adjuvant chemotherapy?
T2.
Or not?
Based on no, sir. T2 tumor.
And N2A also could mean that they are matted lymph node or fixed lymph node. Okay.
Yes, sir.
So if they are matted lymph node or fixed lymph node, then the interpretation is that there has been extranodal spread of the tumor.
Yes.
So if a patient has extranodal spread of the tumor, then that might be constitute an indication for axillary radiotherapy also. Okay.
Yes.
Extranodal spread is an indication for axillary radiotherapy, and it can manifest by matted lymph node, which is N2A.
So you got the point, John. If there is any node positivity, you are going to give a radiotherapy to the bed, not to the axilla.
Yes, sir.
So if there is an ECS, that is extracapsular spread, where do you see the extracapsular spread? In the main specimen or in the axillary nodes?
In the axillary nodes, sir.
Okay. So you have a tumor positivity, it is IDC, and nodes, 2 nodes are positive. So now lymphovascular invasion, is it important or not?
Yes, sir.
Is already positive. LVA doesn't make sense. Only after you will get a node.
Sorry, sir, I couldn't hear you, sir.
Once the node is most criteria is whether or not ECS is extracapsular, that is beyond the capsule of the limb.
Yes.
So that's what I was telling. So when ECS is there, they have to definitely give an axillary radiation. So radiation is determined by the nodal status, and chemotherapy, adjuvant chemotherapy indication is determined by the T size or the tumor size.
Yes.
Okay, not by the N2A.
Yes.
But most important thing is all these things we are discussing without having a IHC report. Suppose you are having a IHC report as ER positive, PR positive, and HER2 new 3+. So how will you plan the adjuvant?
If ER/PR positive and HER2 positive, I would like to give an adjuvant therapy of trastuzumab and paclitaxel, sir.
How many cycles they are planning to give?
4 cycles, 4 21-day cycles, sir.
Okay, why not doxorubicin here?
Sorry, sir.
Why not doxorubicin, adriamycin based chemotherapy? Why are you not planning here?
Usually in HER2 negative and ER/PR negative tumors, we would prefer to give adriamycin and cyclophosphamide, sir.
No. The reason is, if you are planning to give trastuzumab as an immediate adjuvant therapy, you don't combine it with adriamycin because it is both are cardiotoxic. So that's the reason. So if you are planning to give an adriamycin based chemotherapy, you can plan it like adriamycin based chemotherapy for first 4 cycles. And subsequent 4 cycles, you can give a non-adriamycin based chemotherapy like a paclitaxel or a docetaxel. And during that time, you can combine with the trastuzumab. So when will you want to give a radiation? Is radiation indicated in this patient? Radiation indicated or not?
In this patient, yes, sir, because there were multiple positive lymph nodes in the axilla, sir.
So how will you plan the radiation? When you will plan it? You want to give along with the chemotherapy or after chemotherapy? Because trastuzumab, how long you will be giving the trastuzumab?
For 1 year, sir.
1 year. So you want to do a radiation after 1 year or before that? When will you time it? At what time after the surgery will do it?
After 1 month, sir.
After?
3 weeks, sir.
No. So after 3 weeks means the patient will be in adjuvant chemotherapy, no? So you want to give a concurrent chemo radiation?
No, sir.
So adjuvant treatment in breast cancer is always sequential. So initially you plan the chemotherapy alone, and usually it will be for 6 to 8 cycles. So once the chemotherapy is completed, you give the radiation. So if it is a breast conservation surgery, you give a radiation to the breast and a boost radiation to the tumor bed. If it is a modified radical mastectomy without extracapsular spread, you give only to the chest wall. If it is with extracapsular spread, you give also to the axilla. So after completion of the radiation, you will continue with the targeted therapy alone.
Yes.
So which investigation you would like to do when the patient is having the targeted therapy? Any investigation you want to do? You want to monitor any of the patient's parameter?
I would like to monitor the LFT, and also I would like to do a echo for the patient, sir.
Why do you want to monitor LFT in the patient receiving trastuzumab?
Hepatotoxicity.
No. Actually, trastuzumab's main side effect is cardiotoxic. You need not monitor the LFT. Only echo will be sufficient. After 6 cycles, you can monitor. So what are the different methods you can give? You can give monthly or weekly or once in 3 weeks? How you give trastuzumab?
Transfusumab, we give we start with 4 milligram, then we give 2 milligram weekly, sir.
Okay, so you can give either weekly or you can give once in 3 weeks. So loading dose is 8 milligram per kilogram body weight, and continuation dose is 6 milligram per kilogram body weight if it is once in 3 weeks. And as you said, it will be 2 milligram per kilogram body weight if it is weekly. So ideal thing is to give it once in 3 weeks.
Yes.
And patient is right-sided breast cancer. Okay.
Yes, sir.
In which side you want to give the chemotherapy, right side or left side?
Sorry, sir. The
No,
opposite
which
limb.
side? Which limb? Which limb you want to give?
The opposite limb, sir.
Why do you want to give it in the opposite limb? You can give in this ipsilateral limb. No, there will be more perfusion.
Because of chance of lymphedema and for that patient, sir.
Okay. So once the chemo, you have completed 1 year of trastuzumab. Okay. So what adjuvant is still pending? Patient is ER/PR positive.
We can start the patient on hormone therapy, sir. So
no, in most of the answers, what you're telling is we can. It is not can. We have to.
We should.
So
we
there
should. We should start
These are
hormone
all
therapy.
guidelines. These are all guidelines we have to follow. Okay. So what hormone therapy you want to give?
Premenopausal tamoxifen, postmenopausal aromatase inhibitors like letrozole or anastrozole.
Is this patient premenopausal or postmenopausal?
Premenopausal, sir.
Okay. Chemotherapy, what happens to the menstruation? It gets exaggerated, reduced.
Chemotherapy itself can cause reduced menses or mimic menopause, sir.
Yeah, it's something called chemical oophorectomy.
Yes, sir.
So what you would like to give? So suppose this patient is a postmenopausal lady. What you would like to give?
If this patient was menopause, postmenopause patient, I would like to give letrozole, sir, anastrozole, aromatase inhibitor, sir.
You are telling 3 drugs. Which one you want to give?
Aromatase inhibitor, sir, for this patient.
Okay. Do you want to monitor something before starting aromatase inhibitors? You do something, some investigation?
Yes, sir. One would be bone density. Other one will be a uterine scan, and also to check for DVT, sir.
Why DVT?
Sorry, DVT is for tamoxifen, sir. Only uterine thickness and bone density.
So bone mineral density scan, BMD DEXA scan is sufficient before starting aromatase inhibitors. So reason is, what is the reason?
Osteoporosis, sir.
Yeah. So what is the effect of bone by tamoxifen and aromatase inhibitors? What is the difference? Which one increases, which one decreases the density?
Aromatase inhibitors decrease the density, sir.
So suppose the patient is postmenopausal, bone density
Yes,
is not adequate, patient is osteoporotic or osteopenic. What would you like to do? You want to stop aromatase inhibitors or you want to give something else?
Bisphosphonates we can give, sir.
So what are they bisphosphonates? Any drug you know of?
Not sure, sir.
Okay. So before starting bisphosphonates, do you want to check anything in the oral or in the blood?
It has a chance of osteonecrosis of the jaw, sir.
Yes, osteonecrosis can happen. So you have to check for caries tooth. And in the blood,
Yes.
what would you like to see?
Calcium level and
You have to see urea
Yeah,
creatinine. So urea creatinine has to be monitored because.
Yes, sir.
Sir, nephrotalk.
Sorry, sir. I didn't get the last part, sir.
No, you have to check the urine value. Urea creatinine value.
Yes, and this patient you have checked, so
Because
it was
this
normal,
one.
sir. Urea creatinine. RFP one.
Yeah. Okay, got it. So any other information you want to give?
No, sir. Nothing else in the patient we have done, sir.
So patient is treated, completed, surgery, chemotherapy, hormone. How long you would like to give? You want to
5
give
years.
hormone tablet?
5 years, sir.
5 years. If it is premenopausal, you are giving tamoxifen.
5 years, sir, but there's high risk of.
Now, as per the present guidelines, tamoxifen is for 10 years and aromatase inhibitors is for 5 years.
5 years, yes.
Anything else, sir? Suresh Kumar, sir?
Fair enough. Yes, you are completed completely.
So most important thing is after the completion of all the treatment, main thing is you have to keep the patient on follow-up.
Follow-up, yes, sir.
So why do you want to keep a cancer patient on follow-up?
To look for any signs of recurrence, sir.
Yes.
Anything
else?
Distant mets?
Yes. So recurrence include both local recurrence and distal recurrence or metastatic recurrence.
Yes.
Anything else?
Yes, sir. And if the patient is
So
on adjuvant therapy, the side effects of adjuvant or hormonal therapy has to be looked for, sir.
Yes, very good. So main thing is long-term complications of our treatment. So surgery can produce lymphedema, chemotherapy can produce neutropenia, and trastuzumab can produce cardiotoxicity, and hormonal therapy can cause uterine bleeding. So such cases can happen. So to keep the patient, all malignant patient has to be kept on long-term follow-up.
Yes, sir.
Yeah, very good
What
presentation.
are the various ways to prevent the lymphedema in a patient with a breast cancer? You have done MRM for that patient. What are the various ways to prevent the lymphedema?
As in post-operatively, sir?
Intraoperative, start from the intraoperative or even the preoperative.
Preoperative, the physiotherapy should be taught preoperatively to the patient itself. So
yes.
Post-operatively, the patient will be able to do it. Intraoperatively, the axillary dissection.
What precautions you will take in the axillary dissection to prevent the lymphedema?
Not sure, sir.
What should be your upper level of dissection for the axilla?
The axillary vein should be the upper level of dissection, sir.
Yes. So one should not dissect above the axillary vein.
Axillary, yes, sir.
And then?
Post-operatively,
to prevent the lymphoria, you know?
Yes, sir.
There is a lymphoria is there. So if you find there are lymphatics which are there, you may have to tie them there, so that the patient does not have the lymphoria.
Yes.
Okay. Post-operative?
Post-operative physiotherapy and if patient is developing edema, lifting the limb elevation and also compression stocking, so for the upper limb.
Yes.
Compression.
So if the patient develops the lymphedema, and then you should not give the chemotherapy in the same arm. No?
Same arm.
You should not take even the blood pressure in the same arm. And if you have to take the blood pressure of the patient, that should be taken in the opposite arm.
Yes.
No infection in that area. in that particular arm. So if the patient is developing a lymphedema, what can you do for that?
Compression, limb elevation. Yes, sir.
What else? Various type of massage therapy are there. Okay, you can give the various type of the massage. Any operative treatment for the lymphedema?
Only debulk. Not sure, sir. Debulking of the
do the bypass from the lymph nodes, you know?
Lymph nodes, yes.
Lympho bypasses, lymphovenous bypasses, and then some people also use the silastic tube for that. Okay. So these are the various ways you can, if the patient develops a lymphedema, you can do that. But it is always better to prevent the lymphedema. And one should not give the two treatments usually to the axilla, combining the surgery as well as the radiotherapy. If you are giving both the treatments, there's a very high chance of having the lymphedema. So you should do a good axillary dissection so that the patient does not require the, but you know, if there is a pathological problem, is there extranodal spread is there and all those problems which are there, you have to give the radiotherapy. But if it's a combined treatment, it's there is much more chance of having the lymphedema. Okay. Yes. Thank you. Dr. Kanagal, can you stop now?
Yes, sir. Any questions from you, Dr. John?
Sir?
Any doubts or any clarification from you, Dr. John?
No, sir.
Thank you very much. I thank you, Professor, especially Dr. Shanai, sir, for allowing you to present here. Faculty Ibrahim, sir, Suresh, sir, Sahai, sir, any questions, sir? Karnakaran, sir?
No, I think we have almost covered everything. So in postgraduate point of view, for surgical practice, the most thing is, as sir was telling, prevention is better than cure in lymphedema. So we have to take all type of precautions. Doing a breast surgery is very easy, but preventing lymphedema is very important in patient's point of view. You have to keep that in mind.
Yes.
Overall, very good presentation. Congratulations.
Kanna, sir, can we call it close, sir? Suresh,
yeah, please. Yeah, please.
Thank you very much, both Dr. Santosh and Dr. John, for contributing your time and taking all the efforts to present a case here. So, friends, thank you very much for joining this evening. So, the Gujarat Surgical Society has asked for 1 slots every week for another 4 weeks because they want to join us for their academic teaching program. So, I'm sure our faculty will be kind enough to accept their request. And 1 will be for the other chance for the other presenters. So that is the upcoming plan. And we look forward for subsequent events on all Fridays. Thank you very much. Good night, sir. Good night, sir.
Good night, sir. Thank you, sir.